Hello, everyone. My name is Jonathan Fritz. I'm the Chief Innovation Officer for Chime. It's my pleasure to welcome everyone to today's Chime Innovation Beyond the Edge. This 12-part series is designed to share creative problem solving in response to COVID-19 and highlight innovations implemented by your peers. Today's session is Innovation at Stanford Children's Health. I'm very excited to hear from Natalie, a great member of Chime. A special thank you to DrFirst, our supporter for today's session. We know you're incredibly busy at this time, so we really appreciate you joining today. A couple of words I'd like to mention about why we are doing this sort of session. We're presenting this because there are many challenges and problems, and these challenges and problems present opportunity for creative problem solving. This is, in my opinion, at the core of innovation, and we want to celebrate the value and good that comes from that. Chime members have faced many challenges, stemming from sudden remote workforce, spinning up and training clinicians on telehealth, infrastructure, resource constraints, and now looking at restarting elective clinical procedures and the support that's necessary for that. So looking at this next phase of the war, transitioning to what a new normal might look like, and what does that even look like? From what I've seen, our members and our partners are really some of the most creative problem solvers and really leading innovators. Innovation isn't all about bright, shiny objects, and it is really focused on impacting and saving lives when it comes to healthcare. And that is the most impactful and valuable innovations, period. So a few words I'd like to mention before we get the presentation going. Our session will have three main parts. One, a presentation from our speaker. Two, virtual roundtable discussions of 4 to 6 people, so everyone can have a candid discussion on the topic presented. And 3, the Q&A with our speaker. First, we're going to hear a presentation by Natalie Pageler, the CMIO of Stanford Children's Health. At the end of the virtual roundtable discussions, we'll bring everyone back together for a Q&A with Natalie. If you're unfamiliar with breakout rooms, that's okay. I'll provide brief instructions prior to splitting participants into the breakout rooms. We'll have everyone muted during the session. If you'd like to ask a question, please use the chat function to alert the team. The chat window will appear on your right side panel. To ask a question, type your message inside the panel and press the send key. Questions for Natalie can be posed in the chat function during the presentation or after we come back from the breakout rooms. I will ask the questions in the order they were received. We'll try to answer as many questions as possible at the end of the presentation. However, there's a chance that we won't get to everyone. If that happens, we'll collect all unanswered questions and send responses via email to the attendee list. Also, we are recording this presentation. This will be saved and stored on the Chime site, so you can go back and review any details once we finish. Discussions within the breakout rooms will not be recorded. If you have difficulty listening to the live audio stream through your computer speakers, keep in mind that you can connect to audio via phone. If you need help with that or any other technical detail, please use the chat window to send us your questions. For those connecting via phone and your computer, please message the host with your name and phone number. Our host will then merge your phone and computer connections. Lastly, by attending today's full session, the presentation and virtual roundtable discussions, you will earn 1 continuing education for CHCIO, CFCHE, and CHISL certifications. We will review the attendee list following this session and distribute CEUs accordingly. With that said, I'm going to hand it over to Kurt Hess, Senior Vice President of Sales at DrFirst, to introduce our speaker for today. Both Kurt and DrFirst have been excellent friends of Chime, and we appreciate their support as one of our Innovation Beyond the Edge series supporters and supporter for today's session. Kurt?
Thank you, Jonathan. It is definitely our pleasure to support this event and support all of the folks that are on the front line of fighting this very, very nasty disease. And so thank all of those that are on the line today for taking time out to listen to the presentation. I'm happy to introduce today's speaker, Dr. Natalie Pageler. Natalie currently serves as the Chief Medical Information Officer at Stanford Children's Health, Associate Program Director for Stanford's Clinical Informatics Fellowship, and an Associate Professor of Pediatric Critical Care at Stanford University School of Medicine. Through her clinical and administrative positions, she has spearheaded the development of the Stanford Children's Digital Health Program, helped implement novel programs and tools to enhance provider efficiency and practice experience, and has developed innovative computerized clinical decision support tools to provide point-of-care education to clinicians and enhance the quality of care, efficiency, and patient safety. If that wasn't enough, she also actively shapes the curriculum for the emerging specialty of clinical informatics by co-authoring articles on the topic for the Journal of American Medical Association, and is serving as chair-elect for the National Committee of Clinical Informatics Program Directors. That said, Natalie, I will turn it over to you for the presentation. Thank you.
Thank you, Jonathan and Kurt. I really appreciate the warm introductions. And it is my pleasure today to talk about innovation from the perspective of Stanford Children's, as well as children's hospitals across the country. So let me just start with a little bit about pediatrics and pediatric innovation. This is obviously a topic that is near and dear to my heart, but I realize that for many of you, unless you are at a children's hospital, pediatrics may be a relatively small part of your practice. So I'm just going to take a moment to talk about why I care about it so much and why I hope you also understand and realize the impact of pediatrics and pediatric innovation. So pediatric hospital care or healthcare takes up a relatively small amount of our overall healthcare system. Only about 8% of our spending nationally goes to pediatrics. But when you look at the numbers, more than 25% of our population is under the age of 20. And you take it even further, 100% of us were children at one time. So it's incredibly important to every single one of us that we start off well and start off healthy. And we know that the healthcare, the health status of children affects their health and their well-being and their success for a lifetime. Additionally, there's a great working paper for the National Bureau of Economic Research just last year, looking at the impact of dollars spent on children's health and children's education, and showing that there is the most value. There's actually an ROI for dollars that go into pediatric care as opposed to adult care, where every dollar that goes in adult care may lead to more money being spent. In pediatric care, every dollar that goes in can lead to up to $5 in return. So you can have significant ROI. But we do it for the smiles, for the joy, for the families, for the love that we see. And what you're seeing in the background right now is a picture of Stanford Children's Health and our new building, our new playgrounds. It was generously sponsored by Lucille Packard, and she had a real vision to nourish the hearts and minds and souls of every child. And that's why you see the great play structures, the natural beauty. It's just an incredible place to receive care and to work. Thankfully, despite the fact that 1.25 of our population is pediatric care, thankfully most children are very healthy. And what this means is that our subspecialists are few and far between, because we don't need a whole lot of pediatric subspecialists to take care of our entire population. And these aspects lead to some of our innovative approaches. So what I'm going to talk through are some of the innovative approaches that have come out of our need to connect with the pediatric subspecialists across the nation. Some of our need to come together to bring our research and our learnings and our collective expertise to form new standards of care, to form new bodies of knowledge, and to really figure out the right way to perform pediatric care. Because we are so spread out, because subspecialists are so rare in pediatrics, it is absolutely critical that we bring our numbers together in order to figure out the right path forward. One such example is in the area of artificial intelligence. So as we all know, artificial intelligence in imaging in particular is incredibly exciting. There is lots of potential, but very little of it has made it into the healthcare setting in a rigorous way. At Stanford, we're lucky enough to have the Center for Artificial Intelligence in Medical Imaging. And we have a very talented group of pediatric radiologists who are trying to pave the way for children nationally and internationally to have a higher level of care because of collaboration in artificial intelligence. Their first case study was looking at bone age. So for those of you who don't know, in order to figure out bone age, the relative age of a patient's bones, that can give clues about genetic issues or growth issues or endocrine issues. The previous standard of care was to look at this very old atlas and take an X-ray image and then flip this atlas and find the atlas that was the picture that most closely matched the picture of this patient. Not very state-of-the-art. What our group did was launch a national competition to develop an artificial intelligence algorithm to better identify pediatric bone age. But again, our numbers are very small. And what our group wanted to do was to truly take a translational research study, to take this algorithm, which had been developed in vitro, and test it in the in vivo, in the hospital setting, so that we could truly understand the impact of this algorithm on medical care. In order to get the numbers to do that in a meaningful way, they had to organize a collaborative group across the nation. They worked closely with 6 different hospitals across the country. They created an integrated system with our new algorithm and our radiology reporting information systems, and pre-populated each report with the guidance from that algorithm. So that in and of itself was novel and exciting. But again, the key was to get enough numbers. So they then took this process and copied it in 5 different organizations. Each time they copied it, it became faster and faster. So the initial process at Stanford took about 18 months. By the time they were doing the 6th organization, it took about 4 months to get through the entire process. With this, we're able to conduct a multi-center randomized controlled trial of an AI algorithm in pediatric bone age, and show that it could be done safely and could be done much more efficiently than the traditional methods. But again, it was this collaboration and this partnership across the nation that was critical. Similarly, when we don't have that level of randomized controlled trial, especially in pediatrics where we have small populations and we have a lack of evidence, we are often challenged to figure out what our standards of care are from our best practices, from our experts, to come up with some consensus that will then allow us to test those hypotheses and those practices in a more meaningful way. So another example of innovation that was implemented at Stanford Children's, but is the product of a national collaborative, is this smart transfusion guidance. There are lots of challenges with blood transfusions, and if you don't do them in the right setting, you can have serious, significant clinical consequences. But if you do transfusions that are unwarranted, you can also have reactions that can be dangerous, or use these precious resources unnecessarily. So this group called TAXI, which is an international group, looked at all of the best evidence and created a standardized tool that is a rather complicated decision tree to guide our pediatric best practices for transfusion in pediatric critical care patients. What we did at Stanford was to make this an electronic tool, to make this a clinical decision support tool that is hosted on the internet, on the web, but that can be integrated with any EHR. Thereby taking our best body of knowledge that is spread out across the world and placing it at the fingertips of any pediatrician who needs it in real time. But beyond the need to bring experts together in an asynchronous manner like that, we also have a need to bring experts together at just the right time to enable the most innovative and radical learning that you can imagine. So what you're seeing here is a case of fetal telesurgery. What does that mean? Well, we had our maternal fetal medicine physicians, so Yair Blumenfeld, one of our experts, was learning new techniques for fetal surgery. It turns out, again, the experts for this type of process are few and far between, and he was getting guidance from some physicians in Texas. He flew out there, he learned some of their techniques, but he was ready to come back and do it at Stanford Children's for the first time on his own, or kind of on his own. What we set up with the help of Alir Kulali, our incredible director of clinical technology, was a fully enabled operating room ready for telesurgery. The surgeons in Texas could see into the room, could see into the fetoscope to see the surgical field, could see the vitals, could see all of the information that they would be able to see in a regular OR. Their voices could be heard over the speakers in the room and could guide Yair as he was performing this incredibly delicate surgery. They've now done 2 surgeries like this. One was a patient who had a spinal cord defect. She was born several months later with legs kicking and healthy. Another one had a tumor that was removed, again, as a fetus while still in the mother's womb, also born healthy and without any sequelae. Stories like these give us hope and show us what's going to be possible in the future. This was a case where we were learning, but it opens up your imagination for the ways that new education, new medical education can be delivered around the world, so that the expertise that you're seeing in some of these elite children's hospitals that again are few and far between can now be taken to any corner of the world. In the time of COVID, in the time of decreased travel, in the time of a need to limit the amount of people that are going back and forth, this becomes even more important. And so tools like this are enabling us to educate each other, to support each other, even when we cannot be next to each other. But just as our providers are far apart, and just as our providers must learn to support each other remotely, we also have our patients who are often not anywhere near a quaternary children's hospital. And it becomes even more important, especially in this time of COVID, that we are able to stay connected to them whenever and wherever they need us. At Stanford Children's, we have a quickly evolving digital health program where we are using telehealth like everybody. During the time of COVID, we went from an average of 20 telehealth visits a day to over 750 telehealth visits a day now in just a matter of weeks. But we also need to stay connected with our patients in between those visits. We also need to be able to proactively support our patients instead of just reactively intervening when a problem has occurred. We have been actively developing a diabetes digital health program. In fact, several years ago, we were one of the first organizations to use Apple Care Kit to have continuous glucose monitoring directly uploaded into our patient portal and into our EHR. We have continued to expand that and now can do the same type of monitoring whether you have an Android type phone or an Apple phone. And we've continued to expand our models to allow other sources of data to be entered into our Stanford Children's app and our Link app, which is developed for remote monitoring. This type of innovation is the next wave and will become the standard of care to allow our children who may be at any corner of the world to receive continuous expert support to maintain their healthiest selves, to decrease the impact on their lives, decrease the missed days of school, decrease the missed days of their family's work, and help them to achieve and become the successful adults that they can become if they have the right support. I am so excited about these developments. I'm so excited about the partnership that I have with children's hospitals across the country, and so thankful for the constant sharing of learnings and of knowledge and of new developments so that we continue to advance the health of children across the world. Thank you.
Natalie, first question actually comes from Chime team member, former CIO, Tim Stettheimer. Can you describe the approach you mentioned with innovation that involves experimentation and really expand upon that?
Gosh, Tim, starting with the easy questions. So yeah, no, I think it's incredibly important to be willing to take risks in innovation. And I am lucky enough to be on the Stanford campus where we have a rich history of research across the campus and within the School of Medicine. And so natural inclination towards experimentation. And we have really taken those research practices and applied them in our clinical practice setting, like I said, in the kind of translational clinical research aspect. And what that means is that both from a formalized research aspect, but also just from our approach within our information services department and an operational standpoint, you have to give yourself some room for experimentation, for trying different things, for failing fast when something doesn't work and switching it to another mode, versus giving yourself a little bit of leash to go down a certain path and really follow it through and see where it ends. So I think the critical piece in that is having some type of formal evaluation, because it's so easy to experiment with multiple different concepts and then not really have clear data about what the outcomes were. So I think even when we're not doing formalized research with our research partners at the School of Medicine, taking that approach where what are the outcomes you're looking for, how are you going to measure those, how are you going to determine success or failure, and what are going to be your cutoff points for saying, yes, this is worth continuing to pursue, or hey, nope, this is not meeting our needs, definitely not going in the right directions, and we're going to call it quits here. So I think experimentation is absolutely critical to finding the right innovative paths forward.
Well, thanks.
Excellent. Thank you, Natalie. So I have a question. I spent about a week on Stanford's campus, and Dr. Abraham Verghese was one of the professors, and he talks about the healing bond and the doctor's touch. Given the significant move to telehealth, like you mentioned, dramatic increase obviously related to COVID-19. Can you talk a little bit about what sort of process through innovation and maybe even experimentation, you may go through or others may go through. And it could be pediatric specific, or it could be across healthcare to really address that kind of healing touch, but through telehealth.
Yeah, so Dr. Verghese has done incredible work, as you can imagine, and he's created a group called Presence 5, which is a group that has identified 5 key practices that are critical towards developing a healing relationship between the provider and the patient. And interestingly, it is, he is an internal medicine doctor, and their work is mostly focused on the internal medicine side. And with the COVID outbreak, what they did was realize, wow, we're suddenly going to be practicing and delivering medicine in a way that most people had never done before. And how do you take those principles and apply them in the digital health space? And so they did just that. They took their 5 principles, they looked at the literature on website manner and created a video for how to translate those 5 principles into the telehealth setting. And there's a great video that's actually on YouTube right now. If you look up Presence 5, you'll see their work that they're pushing out to help give physicians some concrete tips for developing that healing relationship, even despite this lack of personal, physical connection. And so we saw that on the pediatric side, and there are some slight differences for digital health in the adult space versus the pediatric space. So for example, in the adult space, it is typically communicated that patients may speak less on telehealth, may feel uncomfortable via video, and may need to be encouraged to speak more. Interestingly, in the pediatric space, we are finding just the opposite anecdotally, and this is a study waiting to happen, but where adolescents especially, and even younger kids who may be digital natives, may be more comfortable with talking to their friends via FaceTime, seem to talk more on telehealth. And so anyway, we are now partnering with this Presence 5 group to think about how do they take those 5 principles and apply it in the pediatric telehealth space, both for some kind of quick learnings based, that are kind of common sense that you may not necessarily think about, but then also taking that research a step further to really understand how do you maximize and optimize that relationship in a digital health world.
Excellent. Thank you, Natalie. You also mentioned that a key part of one of your innovation efforts was a collaboration and partnership across the nation. Some of our members are at smaller organizations, or maybe not have the capabilities or the resources to necessarily partner across the nation. Like Stanford does. Do you have any recommendations or other words of advice for how our members might be able to do that?
So I think there are always opportunities to partner in different ways. And so there is the kind of formalized, multi-center randomized controlled trial that I talked about with the Bone Age AI algorithm, which is, that is a significant resource has a significant resource requirement and is a big effort. But there's much lower level just by making those connections and having a large network of people you can turn to when you have a question. We're all dealing with the same issues, more or less. It's really important to identify those networks early on so that you have colleagues that you can turn to. So Chime, obviously, a huge network, a source of support for all of us. Similarly, AMDIS or AMIA, or I help run a pediatric listserv for pediatric CMIOs, CMIO for kids. And then similarly, I was just saying in the breakout group, we've taken that even smaller for pediatrics and for pediatric informatics, one of the challenges gets to be around adolescents and adolescent privacy, and especially with the ONC final rules right now, trying to understand how that intersects with state law. It becomes very important to have a group of peers within our state. So we now have a California state pediatric informatics group that can work through some of those issues together. So that doesn't take resources, right? Building those, taking the time, it takes time. But beyond time, taking the time to reach out, to join sessions like this, to find the listservs that have your peers in them, to speak up about the work that you're doing so you can identify other people who are doing that same work. That is a huge first building block in creating these collaborations. It doesn't necessarily need to be formal. It doesn't necessarily need to be a multi-center randomized controlled trial to be able to learn from each other.
Excellent. Thank you, Natalie. Really around COVID-19 and any innovations that have come out as a result of that, or friction points that were created from that. Are there any that you'd like to highlight that either you or your team were surprised about, or any in particular that you'd like to discuss? So basically really friction points that were caused by COVID-19 and then innovations that were generated as a result of those.
Yeah, so I think for all of us, the rapid transformation, the rapid transition to a new way of practicing medicine was just, unprecedented. And so, like I said, within several weeks, we went from 20 digital health visits a day, telehealth visits a day, to over 700. And that was a huge ramp up, huge educational need and technology need for both our patients and our providers. I think the question for many of us, and I know this because I've talked with multiple colleagues across the nation, the challenge for many of us was how do we support that both from a provider and a patient standpoint? And so I think it's important to realize, in a situation like this, in a crisis like this, that you can overcome some of your educational and technology barriers with people, and you're able to accomplish a ton by focusing your resources, and your richest resource at that moment is people, to really push things forward. So for example, what we did at Stanford Children's was we immediately, pretty much stopped all other projects that weren't COVID related across the organization and across the information services department. And took the folks that were focused on that other work and redeployed them. So we took more than 50 different analysts from across our department and created several groups to support telehealth. So one was a group that was answering a patient support line. One was a group that was answering a provider support line. One was a group that was doing provider tech checks in their home, so providers could provide telehealth from their home. One was a group that was doing patient phone calls before every visit and was calling the patients, doing a test visit with them, and making sure they had their app downloaded. And then we took our Epic training team and stopped all of their regular Epic training and put them fully on creating digital health training, telehealth training materials, teaching telehealth classes, and doing Q&A sessions with providers. So basically took all of our resources and focused, and that got us through that initial period in the first few weeks. And then now we are looking at how do we transition that back to a more sustainable model. So we have now transitioned that group that was doing the patient phone calls, that has now been moved over to our patient portal help desk. The group that was taking the provider phone calls has now been moved over to our information services help desk. That training team created all of these training materials, which are now hosted on our website and in our health stream systems. And the tech checks have mostly been done. So basically we just focused everybody, reallocated all our resources to get us to that first big bolus, and then now are slowly transitioning to a sustainable production level mode of operating. And I think it's always key to, during a crisis like this, take stock, identify what's critical, what's not, stop the non-critical, and then redeploy your human capital to answer the immediate need.
Thank you, Natalie. Yeah, we heard last week from Dr. Zimlichman at Sheba Medical Center in Israel, and how they focused all of their innovation efforts into what they called battle mode for
Right.
COVID-19. And,
Absolutely.
it was pretty interesting to hear his perspective on when they asked the question of, is innovation necessary? And very quickly they came to the conclusion, yes, it is. And now let's focus on, the battle mode for COVID-19. So
Yep. Yeah, we opened a command center for the entire hospital pretty quickly, and it was, full on emergency level command center that went on for 6 weeks, and you're just prolonged battle mode is totally right.
great. Well, thank you again, Natalie. We really appreciate the time, appreciate your presentation. We will be sending out an email to all of our attendees that include a survey. So please let us know your feedback. This is a new program for Chime, and we're hoping that it meets your needs. So please let us know if it does or if it doesn't. It will help us continue to improve our offerings over time. Once again, thank you to Kurt and DrFirst. Really appreciate your support for Innovation Beyond the Edge. Really appreciate your support of Chime. A couple of upcoming events that we've got, actually 3. We've got a virtual Chime social hour this Thursday at 6 p.m. Eastern Time. Our board member, Rusty Yeager, who's the CIO of Encompass Health, will be our guest host for that. This Friday, we will also be having another Innovation Beyond the Edge session with Keith Perry, who's the CIO of St. Jude's. And next Monday, we'll hear from Dr. Dorfler, the SVP of Clinical Strategy and Development, as well as Associate CMO at Northwell. So please register for the remainder of the Innovation Beyond the Edge sessions, which we've got 4 of them still coming up. And last but not least, thank you very much for your time and your attention. We really appreciate you joining us, especially during this time when we know that you've got 23 million other things vying for your attention. So have a wonderful day and be well.